Thyroid Cancer Center. He served as the president of Korean Society of Otolaryngology Head and Neck Surgery in 2014 and 15, and vice president of Korean Thyroid Association in 16 and 17. Dr. Tae also serves as a general secretary of Korean Society of Thyroid, Head and Neck Surgery and Korean Society of Head and Neck Oncology. Dr. Tae received his MD and PhD from Hanyang University, South Korea in 85 and 95 respectively. His primary clinical research interests include thyroid and parathyroid surgery, especially robotic and endoscopic thyroid surgery and head and neck oncology. He is an expert on robotic thyroid and head and neck surgery. He has published more than 290 articles in peer-reviewed journals. So, ladies and gentlemen, let's invite and ask Dr. Tae to start his oration. Thank you.
Thank you, Chairman, for very kind introductions. And it is my great honor to have the opportunity of ISTS oration. Thank you for your kind invitation and hospitality. And now I would like to talk about my journey to remote access thyroidectomy. The techniques of today's conventional thyroidectomy was developed in the late of the 19th centuries, and Dr. Coker's decreased mortality down to the 0.2%. It is very safe and standardized procedures. It can be performed without any major morbidity. However, it leaves a scar on the neck. Neck scarring is important issue these days because cancer is common in women who are very concerned about neck scarring. Especially the hypertrophic scar are quite common among the East Asian country peoples compared to the Western peoples. So to avoid or minimize neck scarring, various types of remote access thyroidectomy has been developed during the past 2 and 3 decades. This slide shows the history and evolution of various types of robotic and endoscopic thyroidectomy. Among various procedures, these 4 procedures are commonly used these days. I started endoscopy thyroid surgery in 2005 using the transaxillary approach, and I moved to the robotic procedure after introduction of Da Vinci robot in our institute in 2008. And I also performed the post-auricular approach in 2013, and also I began performing transoral thyroidectomy from since 2017. It is slide for the incision for the transaxillary approach. After elevation of a skin flap, external retractor placed to maintain walking space. If you use the axillary port, the breast port, it provides more wide angle between the axilla and breast port, so it minimizes polarization of the robotic instrument. However, breast incision is not favored by some of the surgeons, the patients. This is docking of 4 robotic arms. And this slide shows endoscopic procedure. We can use endoscope rather than robotic procedures. The gastric robotic transaxillary approach allows sufficient thyroid and lateral leg compartment exposure. And the total thyroidectomy and lateral leg dissection is feasible without CO2-related complication. However, it may be challenging to approach to the contralateral lobe through the unilateral incisions. This is a post-auricular incision. Also, you can place it forward through the post-auricular port. This approach provides sufficient exposure lateral compartment for the comprehensive lateral leg dissection without CO2-related complication. However, the working space is very narrow, so it is preferred for patients seeking isolated thyroidectomy or who needed a lateral leg compartment dissections. It is a transfer approach. A transfer approach allows easy access to both the lower and the central compartment with the lowest dissection area to reach the thyroid, and post-operative cosmetic outcome best among remote access thyroid surgery. There is no cutaneous incisions. The BABA allows bilateral access for total thyroidectomy and superior cosmetic outcome. However, invasiveness needed for working space is higher, and areolar incision are not favored by some patients. In comparison of poor procedures, invasiveness needed for working space is the least in transfer approach, and completeness for thoracotomy is superior in barber and transfer approach, and the feasibility of a central leg dissection is best in transfer approach. However, the feasibility of a lateral leg compartment dissection is superior in retroauricular approach. Also, we need to compare between the robotic burst and procedure. The robotic procedure provide high density three-dimensional view. Also, it improved the surgical dexterity and ergonomics. However, endoscopy procedure take a shorter operative time, and it is more cost-effective procedures. The robotic procedure is commonly performed rather than endoscopy procedure in transaxillary barber in retroauricular approach. However, in transfer approach, either endoscopy or robotic procedure are performed using for the transfer approach. Remote access surgery particularly valued for its superior cosmetic outcomes. However, it has been faced with many challenges, and there is some criticism and controversy. Also, the global adoption remains inconsistent, hindered by the variability in clinical indication, geographic and economic factors, and the learning curve and training infrastructures. So the position statement should be required. And we made a consensus statement on remote access thyroidectomy, and this project has been accepted for publication inside this month. I served as a corresponding author for this project. This international consensus statement aims to provide a comprehensive evidence-based guidance on patient selection, surgeon training, surgical approach, and expected outcome. And these 6 international society collaborate for this project. We invited experts from each society, as shown here, and modified therapy methods was applied for this project. In building a successful remote access approach program, several key elements come into play: institutional support, qualified surgeon, cost-effective analysis, and a sharp preparation. And the safety of patients must be the first priority during the steep learning curve. Consensus statement 1, surgeon who wish to offer remote access surgery should be high volume thyroid surgeon performing at least 25 thyroidectomies annually, and the proper training program including cadaveric dissection, clinical observership, and on-site proctoring for the initial cases is likely to result in better outcomes. The most patients motivated to undergo neck surgery without scars are eligible for remote access thyroid surgery. Patients with well-differentiated cancer smaller than 2 centimeters without gross ET are usually eligible for remote access surgery. And the patients with intermediate nodule smaller than 4 centimeters are usually eligible. And the benign tumors smaller than 6 centimeters are usually eligible for remote access surgery. The patient eligibility for remote access surgery is variable depending on the skill and experience of the surgeon and the technique selected. The absolute contraindication include patient with suspected gross ET with invasion to surrounding structures documented on preoperative imaging. Among various approaches, transoral gastric, transaxillary, bilateral, barber, and retroauricular are common use in these days, and each of these procedures has its advantages and limitations. With using the robot, you can get a more, some of them advantage compared to the endoscopy procedures. As you shown here is a meta-study comparing robotic burst endoscopy thyroidectomy during the transoral approach. The complication rate, especially transient recoverable rate, is least in the robotic procedure compared to the endoscopy procedures. So robotic is more safer procedure compared to the endoscopy procedures. And remote access approaches are not minimal invasive surgery, given the extent of a dissection required to establish the working space. It's a very important issue. Also, the neurotoxic parasite surgery is technically challenging and a learning curve to be expected. The surgical safety and complication rates are comparable, or at least not inferior, to the conventional transcervical approach in experienced surgeons. Intraoperative visual monitoring, also near-infrared, needle-and ICG angiography is useful in pneumotoxic surgery. This is the example ICG angiography after injection of ICG. We can ICG illustrate the parasite events, so we can confirm the viability of parasite events. Pneumotoxic surgery has unique risk that should be discussed with the patient as per informed consent, such as CRT-related complications, specific neural injury, and surgical space infection. The CRT embolism has been reported to be very low. However, the actual incidence might be higher than reported and expected. Also, we need to consider the mental of injuries. We need to replace the proper oral incision transfer approach. And surgical space infection is risk with any approach, but theoretically most common in the transfer approach. Remote talk says the lateral compartment neck dissection is feasible, and the extent of a lateral neck dissection is compared to the conventional thyroid, except for the transfer approach, is mainly limited to the dissection of level 3 and level 4 area. And contraindication of pneumotoxic lateral compartment are patients with bulky and multi-level neural metastasis. I recently introduced the transfer lateral selective neck dissection dissecting for the level 3 and level 4 areas. It is very useful. Now I can expand it also level 2 dissection through the transfer approach. The meta-analysis show that the number of lateral lymph node number and extent and other complication rates and estimate the thyroid level are not significantly different between various types of remote access lateral neck dissection procedures. The operate time of remote access approach is usually longer than the conventional approach. And also oncological outcome is important. It's not overlooked in remote thyroidectomy in favor of cosmetic outcome. In experienced hand, oncologic outcome are similar between most types of remote access approach and conventional surgery, as measured by the nodal yield, postoperative thyroglobulin level, and recurrence rate. In a meta-analysis study, they show that overall recurrence rates around 1% in all types of pneumotoxic thyroidectomy and conventional approach. Actually, pneumotoxic thyroid surgery is usually applied for low-risk small-sized tumor. Actually, the prognosis of a low-risk tumor is excellent regardless of a surgical approach. So, pneumotoxic thyroidectomy for low-risk cancer might be acceptable, although we need the long-term follow-up data. In terms of surgical completeness for total thyroidectomy, this meta-analysis showed that transaxial approach showed a little low number of lymph nodes, and also postoperative TG level slightly higher compared to the other BABA and transfer approaches. The most significant advantage is a superior cosmetic outcome compared to the conventional transcervical approaches. In our study, show that the best kind of cosmetic outcome. We recently published the meta study show that in the length the probability analysis, transfer and BABA approach shows highest superior cosmetic outcome rate, followed by transaxillary, followed by retroauricular and mevia, and conventional thyroidectomy. This sequence is very significant result. The boys' quality outcome after remote thyroid surgery are similar or superior to the conventional method. In our study, boys' kinetic index is lower and the highest frequency range is higher in the transfer approach compared to the conventional approach. Also, the swallowing outcome similar between pneumotoxis conventional approaches. This meta-analysis showed that voice handicap index of the transoral and gastric transaxle approach is less than the conventional approach. And in this slide shows post-operative change of voice swallowing outcome compared to the preoperative values. As you can see here, the transaxillary and transoral shows a better outcome in terms of voice handicap index and highest frequency and lowest frequency. It is evaluated in patients without recurrent granular pulse rate. We don't know exact cause of a slightly better voice outcome after remote thyroidectomy in patients without recurrent pulse. But it might be related to the lower laryngotracheal fixation. In robotic endoscopic surgery, there is no skin incision, so the adhesion between skin, subacute, and straight muscle trachea might be lower than conventional approach. The quality of life is comparable or superior to conventional approach. In our study, the propensity scoring, propensity function composite score of post-auriculi and transaxillary is better than the conventional approach up to the post-operative 5 years, as shown here. Informed consent process for transitional surgery should include pneumotoxis alternatives and statement that oncological outcome, complication rate, quality of life at least as good as those of conventional surgery when completed by an experienced surgeon. And the establishment of a center of excellence may result in improved patient outcome via superior surgeon experience. This is summary. Robot access thyroidectomy is safe alternative. The complication rate comparable or not inferior. Oncological outcome are not inferior. And the quality of life, major swallowing, and voice outcome are comparable. Cosmetics is better in pneumotoxis thyroidectomy. However, there are unique complications. Also, appropriate training and preparation are required. And the surgeon and referring doctor need to be familiar with the various treatment options and discuss the approach with the majority of patients. Thank you for your attention.
Thank you very much, sir. Any question for him? Great.